So the way we kind of started teaching last year when we were teaching the year before you is we used to just kind of start with a presentation which would encompass all of the modules and all of the specialties. So there was a little bit in it for everybody, and it's also like you're taught medicine in a very module by module format, but in real life, like I'm sure those of you who've done like things like acute medicine rotations will know that like people don't like present with a module by module presentation. It's just like one thing, and there can be like a million different causes. So that's what we try and do a lot when me and Ahmed do teaching. So that's what we have for you today. So we've got right. If someone's about to tell me that these are a woman's legs, like Ahmed just did, please don't. But yes, okay, let's pretend there's a 54-year-old gentleman who's presenting with this. What would you describe this image as? What would you say is going on in this image in non-scientific terms or scientific terms? Because this is like a classic presentation to A&E. So one leg looks swollen or red, unilateral red swollen leg. You mean calf. So it could be the calf. It might not even be the calf. So to be safe, I would say leg for now, because the calf's at the back. I guess you can kind of see that the calf's swollen. Yeah, but so the presentation is effectively that of swollen legs. And when you're talking about causes of swollen legs, what's like the first important divide that you want to make in your heads? What's the first question you want to ask yourself if you see swollen legs? So thinking about diagnoses is very important, but like there's a very good, so DVT is definitely the first thing you want to think of because it's the thing that could kill someone. But we can split up the causes of a swollen legs. We can use like the good old surgical sieve. We can go by time frame. We can go acute or chronic. There's one other thing. How many legs do we have? Unilateral or bilateral? Yeah. So there's, as with anything in medicine, there's lots of different ways of categorizing things, and categorizing things helps you remember them. Specifically for legs, a really good way to think about it is it unilateral or is it bilateral? So if we go back to DVT, does a DVT generally cause a unilateral swollen leg or a bilateral swollen leg? Generally unilateral, unless they've got some serious like thrombophilia, and then they might present with a bilateral one, but you'd hope not. So DVT is at the top of your list, rightfully so. It is the most important thing to think about in this situation. What other things can cause a unilateral swollen red leg? Cellulitis, so infectious causes, very, very important. Yeah. And we'll talk about cellulitis as well in a minute. Any other things that could cause a one-sided swollen leg? Might have to think a bit outside of the box. There's one more. So trauma, absolutely. By what mechanism could trauma cause a swollen leg? So what happens? There's no wrong answers as usual. Yeah, so it could just be inflammation and from trauma. Yeah, very good. What if you had a traumatic injury that wrecked your lymphatic drainage of your leg? What's that called? I mean, this would have to be a really bad injury. Or it could happen from surgery. What's that called when you wreck the lymphatic drainage? You get a massive leg. So have you heard of lymphedema? You might not have. Don't worry if you haven't. So like something they like for you to be able to distinguish in exams is the difference on examination between edema, like fluid edema, serous fluid edema, and lymphedema. Does anyone know how you tell the difference on examination if you saw a swollen leg and you weren't sure whether it's um, lymphedema or like just some other edema? This doesn't really work in real life, as I'm sure Ahmed can verify, because it's something you just have to learn for exams. So yeah, you could take a sample of the fluid, but yeah. So the thing they like to emphasize is like edema due to things like heart failure or drugs. Basically, non-lymphatic causes of edema tend to pit. So when you press on them, you'll get like a nice dent if you apply pressure, but don't apply too much pressure because the patient will be in pain. So be sensitive. Lymphedema tends not to pit. There is the reason I preface it with that's not necessarily the case in real life is because often you will find lymphedema that does pit, and you will find edema that might not pit. Good. So oops, spoilers. Those are the unilateral causes of a swollen leg. What about bilateral causes? What things have you learned about that can cause both of someone's legs to be swollen? They might not be red. So systemic disorders like heart failure. So why does heart failure cause swollen legs? What's the mechanism? So right-sided heart failure causes swollen legs generally due to a backlog of pressure, which increases the hydrostatic pressure. So you force fluid out. And whenever you say heart failure causing edema, there's always two other similar diseases that you should also think of. Every time you say heart failure, there are two other differentials. Do you know what those would be? So renal failure by a specific mechanism. Yes. Do you know which mechanism? It's a syndrome that you might have heard thrown around a lot. And one other failure is with renal failure. And we'll go over the mechanisms of these in a second, because like if you remember the mechanism, you won't forget these because you'll be able to figure it out. What other organ failing could cause systemic fluid shifts? So nephrotic syndrome is the mechanism by which renal failure can cause edema, and that's because you're losing albumin, so you lose the oncotic pressure that drags liquid into your blood vessels, so it leaks out into your tissues. And liver failure because you lose the ability to synthesize albumin. Absolutely. So there's a systemic disorders that can cause a bilateral swollen legs. What are some other things that can cause bilateral swollen legs that you might have heard of? This is a useful thing to discuss because it's things that like are often misdiagnosed in the hospital. So things like chronic venous insufficiency. Chronic venous insufficiency is the commonest cause of like bilaterally swollen legs that you'll see because most people above a certain age will have some. Okay, what if you had like specific? Wait, I'll show you some images in a minute, actually. So we'll move on. So these are the things you want to be thinking of, and remember that lymphedema can be bilateral as well. Don't forget about drug-induced causes of swollen legs, because remember, everything we give has side effects. So what drugs might you be thinking of if you see someone with some swollen-looking feet and ankles? What drugs can cause that classically? Amlodipine, absolutely. So calcium channel blockers. And a few of these have very, very typical looking pictures. So we're going to play guess the diagnosis. What is this? So immediately you know it's one of the bilateral causes. This is chronic venous insufficiency, and the classic this rash is called lipodermatosclerosis, which is the discoloration that you can see. And yeah, absolutely, the champagne bottle legs is the classical like kind of shape of these patients' legs. Due to chronic venous insufficiency, you kind of treat it. You get them to raise their legs at night if it's not that severe, and you can also give them compression stockings. So going back to our chap who's got a one-sided swollen leg, what's your workup? So what investigations do you want to do? Actually, not just investigations. What else would you want to do for him to figure out what the underlying cause is? And so remember, he only had one-sided. Oh, absolutely. Take a comprehensive history. What else? So here's a bit of a prompt. Remember to try and split it up into bedside, bloods, and specialist. Doppler ultrasound is fantastic, but it would come a bit later. D-dimer has a part to play in the bloods. What else? What else would you do at the bedside? You've taken a comprehensive history. You would probably do an ECG, yeah. Examine the patient. Absolutely. What else? One other thing at the bedside. So you've done ECG, yeah, OBS. You want OBS, and you'd calculate something known as the Wells score, because what does the Wells score tell you? So yeah, so the risk of DVT and how you're going to go ahead and manage it. Something I didn't realize for a few months into year 4 was there's actually 2 Wells scores. There's a Wells score for DVTs and there's a Wells score for PEs. And it's a nightmare, but like there's 2 different ones. Don't memorize, just kind of know roughly what's in a Wells score. But like, if you're going to memorize one, would you memorize one, Ahmed?
Definitely not.
No, definitely don't. Yeah, don't do it. Okay, so bloods, we talked about D-dimer. What other bloods do you want to do? Because D-dimer isn't our go-to blood, right? It's not like the first thing we're going to order. Full blood count. Why do you want that? Sorry, I'm like an old doctor. Just like you have to justify every investigation you want. CRP, ESR if you're worried about cellulitis, yeah. You defo do CRP. I like doing ESR, but like generally, like if you're worried about infections, you don't need to do ESR. But yeah, I'd probably do both. You do clotting, could be an infection, so need white cell count. Absolutely, yeah. You guys know your stuff. Great stuff. On top of this, if it's bilateral, it's also definitely worth doing a urine dip at the bedside if you're worried about nephrotic syndrome. Don't forget to do a culture if you're worried about infection, especially if there's spiking fevers. Cool. And then specialist, you already.
How did you get in? You don't think he doesn't need a key anymore.
Patrick is not muted as per usual. I've muted him. Yeah, you guys already knew Doppler ultrasound, which is great. So, what factors suggest DVT versus cellulitis? So, let's start with on examination. What things might point you towards DVT over cellulitis? There's like one specific thing on examination. 2, I guess. Pain disproportional to touch could well be a DVT. The classical description of pain disproportional to touch is compartment syndrome, though. But yeah, I think like the patients I've seen with DVTs have also got that, though. So I take that. Tender, so they can both be tender. But yeah, DVTs are a bit more tender. Someone mentioned the calves earlier. The calves are like the key difference. Yeah, so you get like really firm calves in a DVT. It's like rock solid. That's not always the case, but for exams, that's generally the case. Yeah, good. Cool. These are some other things to think about. So in history, you might have some VTE risk factors. Any ideas what kind of things predispose venous thromboembolism? I think Izzy might have mentioned a few of these last week, but I can't remember. Recent surgery, recent flight. Yes, those are the big ones. Cancer, immobilized, oral contraceptive pill. Yeah, you know these risk factors. Great. These are risk factors that are definitely worth learning. So cellulitis, calves are often normal. You might see like an entry wound. You generally get higher fevers, and you might get some systemic upset, which is why you're doing blood cultures, and you'll also do a swab if you're worried about this. It's also worth pointing out fevers do not necessarily point to a infection over a clot. You can get both DVTs and PEs where they have fevers for some bizarre reason. Ahmed, I don't know. Do you know the mechanism behind that? I don't.
What, a DVT?
Or a PE causing a fever?
I'll go look it up. I actually don't know.
Yeah, I don't know either, but it's one of those strange things. So yeah, this is like know the difference between these two for like one leg. Management, assuming this is a DVT, is really annoying, and I've kind of made a flowchart for you. I don't really want to spend ages going through it, but because it looks hideous. So it's more complicated than the PE flowchart that I think we did a few months ago. But basically, you do a well score. If it's likely is 2 or more points, so remember that. Try and get a Doppler in less than 4 hours. If that's negative, you do a D-dimer anyway. If you can't get a Doppler in less than 4 hours, you basically treat them as if they have a DVT because it's not worth them deteriorating. If it's unlikely, you just do a D-dimer, and then based on the D-dimer, you choose whether or not you do an ultrasound. So basically, highly likely get the ultrasound, less likely do a D-dimer before you do the ultrasound and use that to guide whether or not you need one. The important thing to know is how you interpret these findings. So if you've got a positive ultrasound, how do you manage the patient? What does a positive ultrasound mean for DVT? It's not a trick question. So yeah, if they have a positive ultrasound, they need to be treated because the ultrasound is diagnostic. If you've got a positive ultrasound, you definitely have a DVT, so you want to treat it. So we'll talk about the options for treatment in a second. But yeah, tinzaparin is a very good option. What if you've got a negative ultrasound scan, but you've got a positive D-dimer? And this is the last one. What would you do then? Because these are all combinations you might well end up with. The one in the middle is something you might not have seen, which is why I put it in. So definitely you would consider other causes of a raised D-dimer. Would you send this person? Would you just leave them as they are, or would you want to follow up? Because like, I'm just interested to see what you would do. But yeah, it's very good because remember the D-dimer is a sensitive test in that it picks up lots of DVTs, but it's not specific because it also picks up lots of other random stuff. We'll talk about these anyway. Yeah, positive ultrasound, diagnostic, anticoagulate, and if they're not suitable for that, mechanical intervention. But we're not going to talk about mechanical intervention today. I'd still give prophylactic dose anticoagulant or maybe discharge with the NOAC. I like, so like that's what I thought I would do. But like apparently what you do is you bring them back in a few days and you rescan them to see if it's got any bigger, which I think is I personally think is bizarre, but that's what NICE like to do. I see Ahmed has just made a face, which means he also seems surprised by this decision.
Yeah.
Yeah. yeah, it doesn't sound very sensible. If it's negative, if everything is negative, definitely consider alternative diagnoses. So do you reckon if someone has cellulitis, what do you reckon their D dimer will be? It doesn't matter if you don't know, just have a guess. What do you think? Yeah. So this is the problem with D dimer. D dimer can be raised in states of infection. So this is why D dimer is always a bit of an iffy thing. So basically, do an ultrasound. If it's positive, you treat it as if they have. You treat it because it means they definitely have one. So options for treatment: you can either give them a low molecular weight heparin, like tinzaparin, dalteparin, or enoxaparin. For OSCEs, learn the doses for one of them. But in reality, they'll give you a BNF, so you just look it up. It's because we had this in our OSCE and they gave us a BNF and we just looked it up. They even told us which one to look up. And then if you don't want to use low molecular weight heparin, which might not, I don't think it's first line anymore. I think you use a NOAC or a DOAC, like a Pixaban or a Viroxaban for first line now. That's like the change in guidance. So yeah, basically anticoagulate them. And anticoagulation is similar to what Mark went over last week with relation to atrial fibrillation. How long you anticoagulate them is depending on whether it's a provoked or unprovoked DVT, but I can't remember the exact cutoff, so that because the guidance has changed. So have a look at nice guidance for that. Management, assuming this is cellulitis, is significantly easier, and it ties in quite well with the antibiotics lecture we did. So here are a few questions for you to answer. So let's start with the first one. What is the likeliest cause of a cellulitis? So what is the bacteria that sits on our skin and is likely to cause an infection? Staph aureus. Yep. Great. What antibiotic did James and I mention is specifically really good against Staph aureus and was basically invented to treat Staph aureus? Fluclox. Absolutely. It's the penicillin that is resistant. That Staph aureus. It's like the only penicillin that was designed to work against Staph aureus. But what happens if it's resistant and they have MRSA? So MRSA is methicillin-resistant Staph aureus, which in practice, in clinical practice, that means it's Staph aureus that's resistant to Fluclox because we don't use methicillin clinically. So doxycycline could work. It's not great against MRSA. There are 3 drugs we go to if we're worried about MRSA. So vancomycin is one of them. And what was that really weird side effect of vancomycin if you give it too quickly that we talked about a few weeks ago? Red man syndrome. Yeah, they just get like this mad rash everywhere. You just need to slow down the infusion. It's pretty rare. You probably won't see it. And then the other 2 are teicoplanin and linezolid, but like I wouldn't worry so much about them. Vancomycin, if you can remember vancomycin for MRSA, you're doing great. So cellulitis management significantly easier. Here's this. Oh, I was meant to animate that, but yeah. So if you see this is not. So this is something that's commonly misdiagnosed in the hospital is bilateral cellulitis. But what this actually is erythema nodosum, which is inflammation of subcutaneous fat pads. And an important differential diagnosis is the causes of erythema nodosum. So does anyone know what is the commonest cause of erythema nodosum? Or what are the categories of causes, rather? Because that's easier than telling me specific diseases. So sarcoidosis is classically associated with erythema nodosum, but sarcoidosis is a very rare disease. Ulcerative colitis is significantly more common than sarcoidosis, but is still pretty rare. So yeah, these are all autoimmune causes, as Jordan has nicely summarized. There's infectious causes that we'll talk about as well in a minute, but still neither of these are the commonest. What else? So vascular causes, so tends not to be vascular, although it's associated with certain vasculitis spectrum conditions. Medications are the commonest cause. Well, Second, because the commonest is idiopathic, and we don't count that as an actual cause because that just means we don't know what's going on. But medications are the commonest cause of this. So do you know what medication that is widely taken across the world is associated with erythema nodosum? The combined oral contraceptive pill, absolutely, yeah. So that's a really important cause. So causes idiopathic, iatrogenic, infectious, autoimmune, and neoplastic. So now if we delve into the categories, so any other drugs you know cause it? There's one group of antibiotics, but it's pretty rogue. So actually, I'm not even going to ask you because you don't need to know it. So sulfonamides are like some old-fashioned antibiotics that we don't really use that often anymore. We use them for certain things, but don't worry too much. Infection, tuberculosis is a big cause of erythema nodosum. Any other infections? That's not a common cause. It is a common cause worldwide. It's not a common cause in the UK. Do you know what infection is the commonest cause in the UK? Commonest infectious cause, sorry. Don't worry if you don't. So herpes simplex is like a very common cause of it as well. And then we spoke about, so what other autoimmune type things can cause it? So yeah, some vasculitis spectrum things can cause it. We've spoken about inflammatory bowel disease, and we talked about sarcoid, which are like the big ones. Crohn's, yeah. So generally, like Crohn's, TB, and sarcoid go into, they're all like these granulomatous diseases, so they all cause kind of similar things. And Behçet's it's not a common cause, but is an important cause of it as well. And I wouldn't worry too much about Behçet's. It's not really a fourth-year condition. It's more a fifth-year condition. But yeah, it's another autoimmune disease. But yeah, those are the important ones. Lupus can cause everything, so I don't like. You don't need to remember that. Neoplastic, you can't guess, so I'm not going to ask you to. But leukemias and lymphomas can cause it too. I can't spell leukemia. I apologize. So this is what lymphedema looks like. This is a very severe case of lymphedema. So what are kind of the causes of, so lymphedema is when your lymphatic system basically gets wrecked, and there's no return back up to your chest. Does anyone know what some of the cause, what would you say in the UK the commonest cause of lymphedema is? So trauma, yeah. So trauma or chemo. So basically, by trauma I mean surgery, because surgery is effectively traumatic to the body. But yeah, when you remove lymph nodes or you cause fibrosis of these, you can get destruction of the lymphatic duct, so you can get lymphedema. Can this be congenital? It can. Do you know what disease causes congenital lymphedema? It tends to be bilateral more than unilateral, but it can be unilateral as well. You don't need to know this. This is definitely off curriculum. Any idea, Jordan? So elephantiasis is the infectious cause of lymphedema. That's an infection, and we'll talk about that because it's one of the weirder infections. It's unlikely to come up, but like it's interesting, and I've seen a case of the free. Obviously not looking that bad. But yeah, so some of the causes: iatrogenic, infectious, neoplastic, congenital. Surgical removal of lymph nodes, you got infections. So do you know what elephantiasis is? What causes the infection? What kind of organism? Yeah, it's a parasitic infection. Yeah, so it's something called a filarial infection. It's a subtype of parasites. Neoplastic, so things like lymphomas can compress the lymphatic drainage, and it can cause everything to back up. And congenital cause is where you don't have lymphatic drainage, and it's called Milroy's disease. You definitely don't need to know that. I just put it on there for completion. Please forget it. Here's some stuff for reference. So elephantiasis is lymphedema due to filarial infection. common pathogens causing it. The commonest is this thing called Wuchereria bancrofti. You don't need to know these. I've just put it on because it's interesting. But like, if you're worried about parasites, the go-to for parasites is either metronidazole, doxycycline, or albendazole. It's always one of those three. That if someone has Google this, it's honestly remarkable and it's terrifying, and it's why it's actually a big deal worldwide. You won't see this in the UK, hopefully. You might see it at the Royal Free if you're lucky. Okay. This is all Ahmed. If you have any questions about swollen legs, let me know. I'll be in the chat. But yeah, Ahmed, cool, great.
Also, just really quickly, there is no confirmed or known mechanism for why VTEs cause a fever. There's theories, but we don't actually know.
Yeah,
possibly clot fragment, irritation. That's what people think. Okay, so we've got Jessica Jones. She's a 32-year-old woman. You are in the situation with the F2 in the emergency department. Jessica's been brought in by ambulance. Member of the public found her just unconscious on the curb, and she started to come around in the ambulance, but she's still quite groggy. So, what is the single most appropriate next investigation? Well, she's just come into ED.
I have a Menti ready.
Ah, nice.
There you go. Sorry, I was meant to post the code, but I forgot. Yeah, have a go.
We'll give you guys a minute for that.
Voting should be open now. Sorry. So if you go to menti.com, I'll put the link in.
Also, since there's 8 of you, if people feel comfortable answering just by voice and feel that would be faster than typing, feel free to. We do not mind at all.
Is it ECG?
We'll give it a bit of time just to see what people say on Menti.
There is an overwhelming majority on Menti.
Okay, what are people going for on Menti?
Everyone has gone for A.
Okay, right. Deliberately misleading question. So the correct answer in this case is B. So the thing you need to remember about the VBGs and why they are really, really useful is that they give you 2 useful things. They give you a lactate, which is a sign of dehydration and acidosis, and they also give you glucose. Glucose is going to be the most reversible thing most quickly and is easily forgotten. You can do the VBG whilst you're setting up the ECG. The ECG is really important. The ECG is in fact the second most important thing on here. But if the person is, if the person is breathing and they have a pulse, that can wait whilst you determine, hang on, is this person hypoglycemic, and is they, are they just going to die because they're hypoglycemic? So deliberately trick question. ECG is definitely the second correct answer here. Quickly, the others, lying and standing blood pressure. Basically, all the others will not affect your immediate management. ECG and VBG will affect your immediate management. Obviously, if she's having a STEMI, that's going to affect your management. If she's hypoglycemic, that's going to affect your management. Right. So, let's say she's just been brought in by ambulance. What sort of things do you want to know? Just put them in the chat or say them out loud, and I'll give you the answers to them. You're the EDF too.
Imagine going straight from year 4 to F2. It's quite
I know.
a jump.
Perfect. Yeah, really good. So she's got no oxygen requirement. Her heart rate is 92. Her blood pressure is 110/72 while she's lying down and 98/68 while she's standing. So there's no postural drop. She's got a rest rate of 17, her SAT's 97 on air, and she's got temperature of 37.2. So for all intents and purposes, she's stable. Good, I like that. No previous history of so let's say, perfect, I like this. Right, very good. Okay, so let's go through those one by one. So first of all, GCS. Her GCS on examination is 12, so she's 3 on eyes, which means that She is responding to voice, but she's not opening them spontaneously. It's a 3 on voice, which means she's making noises, but she's saying words, but they don't really make sense. And 6 on movement, which means that she obeys commands. So that's 12 out of 15. Jessica's gone for a systematic thing, which is really, really good, which is what happened before she lost consciousness. The answer is we don't know, because she was found on the street by a passerby. So the ambulance handover says she was found on the curb by a passerby. She was breathing, but she was not responding. So the passerby called an ambulance. So we don't know what happened before she lost consciousness. Let's say it was Charmaine asking about a previous history of epilepsy. The patient is quite drowsy, so we can't really take much from her, but fortunately on the record, if we've got her next of kin, who's her fiance, and her fiance says no history of seizures or epilepsy. Charmaine asks, how long did she take to recover from it? She's still quite groggy. You wouldn't say she's properly recovered. She's still quite groggy. No history of faints. She has. There's no indication that she's taken any illicit substances or anything. Her pupils are equal and reactive to light. They don't seem dilated. They're about 2 millimeters, which is quite normal. Oh, someone say, past medical history of loss of consciousness, diabetes. Yes, so she has type 1 diabetes. And her blood glucose, very good question. In the ambulance, they did a blood glucose of it was 1.8, and they gave her IM glucagon. But she became rousable. She regained consciousness, but she's still quite confused. Okay, so we're sort of heading towards a picture. So if I sort of make things, so we've got so far that she's got diabetes. Her blood glucose is 1.8, she's given glucagon, and the VBG comes back, and her glucose now is 3.3. So to summarize, pre-fall, we don't know what happened. During fall, if we ask what sort of things are important to ask about during the loss of consciousness. So in this case, we don't know how long she was unconscious for. What other things do we want to know about while she was unconscious? Did she hit her head? Very, very important. Was she incontinent? Good. So whilst you're doing your A2E assessment, there's no signs of incontinence, and there's no signs of head trauma. Did she bite her tongue? Very good. No lacerations to the tongue. So remember, those two things that Jordan and Hannah asked about are signs of an epileptic seizure, where there's loss of sphincter tone and skeletal muscle contraction, particularly in a tonic-clonic seizure. Okay, so those are probably the most important things to ask about during. And remember, sometimes people might say that the patient was sort of twitching. That doesn't necessarily mean that they were having a seizure. Seizures are usually much more violent than that. Twitching could just be because of peripheral hypoxia, because they're not really getting blood. They're not getting blood there. Okay, and afterwards, so Charmaine's asked the most important question, which is how long did it take to recover? And the other thing is, what was the patient like when they recovered? So let's say we'll get to what Jessica's showing in a second. So the most important thing when you have a loss of consciousness history is you want to divide the history into 3 parts, which we've already alluded to. So before the episode, during the episode, and after the episode. So let's talk about before the episode. What symptoms are we going to ask about before the episode? If we can get it from the patient, great. If we can't, if we can get it from a passerby. Ideally, if we can get it, this is really useful. Let's say if the patient was conscious now, what do you want to ask them about? What did you experience? Did you experience what before the episode? Vertigo, dizziness, loss of sight. Perfect. And that's leading you towards what? Aura. Good. Good. So vertigo, dizziness, loss of sight, sweat, tachycardia. Yep. Okay. Good. So tachycardia and palpitations are all pointing us towards sort of a pre-syncopal episode. So this is syncope, this is cardiac related. Laura, headache. What kind of headache might you want to ask about? If the person has lost consciousness, let's say they're around our age, maybe a bit older. What thing do you not want to miss? Yeah, perfect. Thunderclap headache. We don't want to miss a subarachnoid hemorrhage, which can cause sudden loss of consciousness, but the person can become rousable again, just because the person's perfect changes in vision. So if we're thinking about things like an aura, what are we sort of worried or considering? So confusion and aura. So aura so we typically think of auras in terms of migraines, but migraines won't or shouldn't cause a person to lose consciousness. In this context, what condition also comes with an aura before an event happens? Perfect. Yeah. So epilepsy, So Maddie said temporal lobe seizures. The aura basically depends. Some people don't get auras, and they very quickly just suddenly lose consciousness and develop a seizure. Other people know when it's coming on. So, for example, temporal lobe seizures often will have an aura, but because they're temporal lobe, the patient shouldn't really lose consciousness. They might lose awareness. Even generalized seizures, the patient might feel them coming, and that could really be anything. They might get a weird tingly sensation. It might be sort of visual abnormality, like with migraines. We also want to ask about what else. So we've sort of covered the cardio side. We've covered the epilepsy side. If they say they're having chest pain or shortness of breath before they lost consciousness, what might they have had? What are our worst case scenarios? If somebody had chest pain, shortness of breath, and then just blacked out. Yep. So ACS, so STEMI. And what's the other thing? Shortness of breath and chest pain. Yep. PE. Never miss a PE. Don't ever miss a. Don't ever. And PEs can present really non-specifically. Okay. Really good. And if they've had a head injury beforehand, so your things like your epidural hemorrhages, someone got hit on the head, during a game of rugby or something, and then passed out and came back, and you're sort of worried, are they going to lose consciousness again as the hematoma increases? Okay, so we've said the duration, we've said head trauma, we've said seizure-like activity, and obviously were they breathing? For example, if somebody's gone into cardiac arrest and then had a spontaneous return of circulation, they might have stopped breathing for a bit. After the episode, we've talked about the time to get back to normal, any post-ictal symptoms, so after a seizure, that's confusion, feeling fatigued. If the patient's still short of breath or got chest pain, they might be peri-arrest again. So just because they've come back from cardiac arrest doesn't mean that they're out of the woods. So they still might deteriorate again. And then signs of head injury. So what signs of head injury can you think of other than the patient saying, I hit my head? Let's say you're dealing with a patient who is unconscious or drowsy. What sort of things are you looking for? Start with obvious. Noise, yeah, vomit, yeah. So if the patient's vomited, you might be worried they've had a head injury. Yeah, bleeding. If there is a laceration to the head, that has to have gotten there somewhere. Bruising. And what about the really common medical school thing? Yeah, base of skull fractures. Good. So what are your signs of a base of skull fracture? SBAs love this. Real life, you hopefully won't see them. Good. Battle sign and raccoon eyes. So remember, there's base of skull fractures. Your raccoon eyes are what? And you can call them panda eyes as well. I think raccoon eyes is more common in the States because they have raccoons there. Here we call them panda eyes because pandas are cuter. So someone wants to say what battle sign is, because raccoon eyes is fairly obvious. Or panda eyes, sorry, I don't know why I call them raccoon eyes. What's battle sign? Perfect, so post-auricular hematoma, and those are all signs of the base of skull fracture. Okay, investigations. We do the same thing that Anush did with you guys just about 20 minutes ago. So bedside investigations. So give me probably the 3 most important things you want to do at the bedside. And we've already mentioned some of them. Glucose, good. Second most important, at the bedside. Yeah, perfect. Now, in 50% of the population, what test do we always want to do if a patient comes into ED? Because what do we never want to miss? Yes, pregnancy test, because why might somebody with a positive pregnancy test have lost consciousness? Worst case scenario. Again, more of a 5th year thing, but still useful to know. Perfect, ruptured ectopic. You don't want to miss it. Let's say a woman our age could come in with something like that, and you think, oh, maybe it's vasovagal, and then you send them home, and then you find out they died the next day. which has apparently happened at Barnet, which is why they're really, really on it with pregnancy tests. Okay, perfect. And then in terms of bloods, so let's say our VBG is done. What bloods do we want? Somebody who's lost consciousness. We've got IV access for them and everything. What do we want to do? Yes, lactate. So that'll come on the VBG, and that's really useful to show us the patient's hydration status. And also is a marker of sort of anaerobic respiration. Use and ease. Why do we want to know about use and ease? I am being that annoying person who's asking you to justify blood tests. Full blood count, very important. If their severe anemia will cause you to lose consciousness, what else is the FBC useful for? Perfect. Electrolyte abnormalities. People often forget about them, but they will. If you're hyponatremic enough, you will pass out. If you're hypokalemic and you go into cardiac arrest, you will fall to the ground. FBC for anemia, good. What other thing? What other thing on the FBC could be quite useful? What's the other useful thing with FBC? Yay, infections. Why might an infection cause someone to fall over? And bleeds. So Davina said bleeds. Yeah, that'd be good. You'd also want clotting in there as well. What might cause somebody with an infection to drop their blood pressure?
Septic shock.
Yeah, perfect. Patrick said it. Yeah, so if they're perfect. You've all got it. So if they've got sepsis, right. So we've said the pre-syncopal symptoms. We've talked about these. We've talked about post episode symptoms. We've talked about during the episode, and we've talked about investigations. You may, if you know the person's got a history of epilepsy, might do anti-epileptic drug levels. Why might you do that? Perfect. They might have missed their medication or not been taking their medication, and then they've gone and had a seizure. And I've thrown in thyroid function tests. Why might somebody with a thyroid function abnormality have lost consciousness? This one's a bit of a rogue one, and hopefully we never see these anymore in the UK because we can usually doesn't get this bad. But what eventually happens if somebody's hypothyroidism isn't treated? The medical emergency. Myxedemic coma. Perfect. Nice one, Davina. Right. So quickly going over the stuff with Jessica. So we talked about the ambulance handover. So we've said they gave her glucagon. She became rousable, but she's still quite confused. From her fiance, we've got that they had a stomach bug, vomiting and decreased oral intake. She'd gone for a run. That's the last that he'd seen her. She takes a basal bolus insulin regime. No past medical history or drug history. No known allergies and no seizure history. She smokes 20 cigarettes a day. Drinks a bottle of wine each night. Really quickly, does someone want to take a quick stab at her and the number of units that she's taking in every week? Units of alcohol from a bottle of wine a night. Let's say it's about, I don't know, what strength? I don't know, average. Let's say it's a red. Yeah, basically, at the very least, a bottle of wine would be around, of red would be around 7 units. That's a lot. That's 3 times the recommended weekly intake. And why is that a problem with a patient who's taking insulin? What's the problem there? Yeah. Alcohol notoriously messes with insulin levels, so you get really brittle glucose control if you drink a lot and you're a patient with type 1 diabetes. It's why you'd be advised, cut down, avoid binges, especially binges, because shoots up. You take your insulin, you send yourself back into a hypo. So stable, and then you guys have basically done your A2E assessment. Sorry, it's a bit not very readable, but essentially that's a really good point. So Jordan's made a really good point. If she's drunk, she might get the dose wrong as well, and then put herself into a hypo. So she's maintaining her own airway. Her chest is clear, stable. We said GCS 12, no signs of head trauma, nothing like that. We've got her ECG, which is normal, and her urine pregnancy test is normal. No other abnormalities there. Do we want to do a chest X-ray on this lady? Any reason for us to do a chest X-ray? It's not a trick question. Yeah, I agree with Jessica. Can't see a reason. There are some people who like to be thorough, but it's unnecessary radiation, especially in a 32-year-old. You don't want to do that. Do we want a CT head in this lady?
Odds on someone in A&E randomly ordering them a chest X-ray anyway, and then getting roasted by a consultant.
Happens. Seen it.
Yeah.
It will happen. So what do we think about CT head? No idea in nature. Good. We're not sure about the mechanism of injury. Okay, good. So we'll come back to that. We'll come back to that in a minute. We've got another SBA for you guys. So we've got a 57-year-old man brought in by his girlfriend. He tripped over a wire at home, hit his head on a wooden table. He's vomited once, but he hasn't lost consciousness. He didn't have amnesia or any focal neurology. His girlfriend was worried because he was confused for roughly 15 minutes after hitting his head. His GCS is 15, no signs of skull fracture. He thinks he should go home, thinks his girlfriend is being unnecessarily worried. What one reason would you want to do a CT scan on in this man? What's the one thing that's going to make you go, CT? I'll give you guys a minute for that.
Sorry, I just realized the voting was closed. It's open now.
And we should get to a close in the next few minutes, so.
So there's quite a split on this question.
Okay. How's it looking?
Which isn't surprising because there's a lot of correct answers. So 2 people went for A, 2 people went for B, 3 people went for C, and 1 person went for D.
Okay, right. So let's talk through it. So the correct answer is A. Take it like this. Any head injury plus anticoagulant use, you need a CT head within 8 hours. And any head injury. If they're on warfarin or dabigatran or whatever, it doesn't matter if it was just a tiny bump, you might have a subdural. So they need a CT head. Even if they're saying, I'm fine, I want to go home, you want to do a CT head for them. Stroke, if he had a clotting disorder or a bleeding disorder, that would be an indication. But a stroke on its own, and 7 months ago, isn't within the NICE guidance. That sort of more factors into things like thrombolysis, for example. Maybe when you're thinking, oh, would that be contraindicated? But not for a CT head. Vomiting, close, but it's 2 episodes of vomiting. So 2 or more episodes of vomiting. A single one is regarded as fine. 2 or more, then that's an indication for a CT within an hour, so not within 8 hours. The confusion isn't enough. The patient needs to have had half an hour or more of retrograde amnesia, so not remembering the past 30 minutes. Then you do a CT head, but confusion, what some of us might think surprisingly, is not an indication. And just because there was a cut doesn't necessarily mean that a CT is needed. So if there are no signs of a depressed skull fracture or an open skull fracture or a evasive skull fracture, let's say you can't feel any bogginess underneath, then you don't technically need a CT. Quite a few practitioners probably would do a CT just to stay on the safe side, but you don't necessarily need it. So really quickly, before we talk about CT guidance, 2 really important things. So hypoglycemia management. If I am, let's say, conscious and my blood glucose is below 4, so that's technically the cutoff for hypo, but I'm awake, how would we treat my hypo? So I'm awake, but I'm hypoglycemic. I've got a blood glucose of about 2.8. What should you tell me to do? Or, yeah, give me something sweet. Yeah, give me a fast-acting carbohydrate, and you can do that up to 3 times every 15 minutes. If my blood glucose hasn't gone above 4, then what should we technically be doing to me? What's our sort of next step up? So I'm clearly not responding to something oral. Okay, let's say I'm in the community. So I've just sort of sat down and feeling a bit dizzy. So I don't have IV access. What's sort of the next best thing?
What a classic exam question. You could not get IV access.
Yeah.
Denied.
So, and technically somebody with type 1 diabetes should have a hypo kit, which should include this. So, what hormone is responsible for increasing? Yeah, IM injection of what? Yay, perfect. IM glucagon. So IM glucagon should technically be in your in the hypo kit, and paramedics will carry it along with the usual IMs like naloxone and things like that. Now, if I was drowsy or unconscious, the latter being a medical emergency because airway, then you're not obviously going to put leukocyte down my throat. You are going to stab me with IM glucagon. If there's IV access and I haven't responded to glucagon, then what might you give me? So Jordan said dextrose. As an aside, anybody know the volume and concentration? So what percent dextrose and how much of it? You don't actually need to know this year. Perfect. Yeah, you can give 10% or 20%. How much of it do you want to give? Guidance used to be 50%, but 50% glucose looks like treacle. You're literally having to squeeze it down the giving set into the person. It doesn't look nice. It's basically syrup. So you just need 100 milliliters. So 100 milliliters of 10%. So that's your bolus. After that, yeah, you can start them you can start them on sort of a bigger bag, but initially you just give a bolus, so a stat bolus of 100 mils of 10 or 20%. Perfect. Okay. And the other really important thing, so we mentioned this lady had gastroenteritis. Sick day rules for diabetes. What do we tell our patients if they have diabetes? What should they do when they're sick? So there are sort of 3 key points that you should tell them. Yep, monitor BMs regularly. Specifically, the guidance is every 4 hours, including at night. Keep taking your medicines. Apart from one exception, there is one medicine, type 1s won't be using it, patients with type 2. There is one medication or class of medication which you should stop taking if you start to feel unwell. But correct, keep taking your insulin, your metformin, your gliclazide, your sitagliptin, your pioglitazone, your GLP-1 agonist, so you're taking it. One class of medication, the one that makes you, so not sulfonylureas, but a good guess, the one that makes you pee out most of your glucose, well, good, like a third of your glucose. What category of medications is that? What class? For a new one. Yeah, so SGLT2 inhibitors. So SGLT1 is in the duodenum, Jordan. So SGLT2 is the one that's in the proximal convoluted tubule. I'm surprised that I remember that. So the reason for that is actually quite interesting. They predispose you to euglycemic DKA, which sounds completely bizarre, but it's a phenomenon where the person's glucose levels are normal, but their ketone levels, they're in DKA basically. And the mechanism's quite interesting, basically, because you're getting rid of so much glucose. You kind of if you're unwell and your intake reduces, so you're in a sort of starvation state, and then you're already getting rid of so much glucose, your body doubles down and goes, oh my God, I'm starving. So it starts promoting lipolysis, and you're producing lots of free fatty acids, and you get beta oxidation in the liver, and you're getting lots of ketones. So your blood glucose is actually quite normal or even low because you're getting rid of it through the SGLT2 inhibitor, but your ketones are going up because your body thinks that you're in a state of starvation. So, you take their BM and you think, oh, it's fine, it's 8, they're okay. But you measure their blood ketones and then you think, oh God, it's 4. Oh my God, they're in DKA. So SGLT2 inhibitors can give you euglycemic DKA, which is why you tell them to stop that. So we've said monitor your BMs regularly, take your medicine apart from SGLT2 inhibitors, stay hydrated, because remember, that's what kills people in DKA. It's the dehydration. Stay hydrated. If you can't keep food down, sugary drinks, things like ice cream, glucose tablets, and the other really important thing is monitoring for ketones. So really quickly, this is quite small, but it's the CT guidance thing that we talked about. So as you can see at the top, or you might not be able to see, it's not enlarging for me either, but it's something to have a look at if you want in your own time. But basically our patient, so Jessica, as you guys rightly said, should probably go for a CT head because, well, her GCS was 12 at presentation. That's somebody you want to scan to make sure that is there something more insidious going on. We've got our hypoglycemia management here, and we've got our sick day rules for diabetes here. One other important condition with sick day rules is Addison's disease. What are the sick day rules for Addison's, or for anybody on long-term steroids, actually? Anyone on long-term steroids, what's the sick day rule?
Also, just with
steroids.
Yeah,
double.
Sorry, the only thing I was going to point out was I think in the newest A&E guidance, anyone who comes in with drowsiness gets blood ketones because of a risk of euglycemic ketoacidosis, which is more and more common than we thought it was.
Yeah.
So yeah, alongside blood glucose, just do blood ketones.
Yeah. You lose nothing. It's just another blood test, doesn't cost anything, and it's really, really important. So just quickly, just open up the algorithm on another screen so I can actually see it. So anyone who's sustained a head injury should get, this is the algorithm. You've all rightfully said, because we don't know if she's sustained a head injury, sure, there's no sign of it, but she might have hit her head. She comes down this thing. Are any of the following risk factors present? Yes, she has a GCS of less than 13 on initial assessment. So she needs a CT scanner within an hour. Our gentleman, the 52-year-old, if he was on dabigatran, he would need one within 8 hours. So that's just a useful thing to look at. Finally, last slide. This is something, basically, the takeaway I want from from this second half for you guys is if someone comes in with loss of consciousness and you follow the pre-loss of consciousness, during loss of consciousness, post-loss of consciousness history pattern, you will not miss anything dangerous. That is by far the most comprehensive way to approach loss of consciousness. And then whilst you're thinking about etiology, I'd like you to sort of think about it like this. So really sort of simple question, why do people lose consciousness? What organ has been affected in order for somebody to lose consciousness? But what organ dysfunction will cause you to, so your heart block can cause, why does your heart block cause a loss of consciousness or your bradycardia? Yeah, your brain. So loss of consciousness is basically secondary to some form of cerebral dysfunction. So the way I like to divide it, you know how with your AKI, we're taught pre-renal causes, renal intrinsic causes, and post-renal causes. Do the same thing with this. So you can divide it into pre-neural causes of loss of consciousness, and that's most of it. So we've talked about cardiac. Jessica's mentioned, for example, heart blocks, arrhythmias, something vasovagal. We've talked about rest. We've talked about PEs, pneumothorax, anything that can cause hypoxia. We've talked about metabolic causes like hypoglycemia. Hyponatremia was mentioned earlier. If somebody's hyperventilating and they go into hypocapnia and lose their respiratory drive, such as, for example, during a panic attack, they can lose consciousness. So, so a panic attack can cause a faint. Distributive shock is really important. We said sepsis, anaphylaxis, so hopefully you'd recognize the anaphylaxis before then. Toxins, so uremia, hepatic encephalopathy, all of these things. And let's not forget endo. We've talked about Addison's and myxedemic coma. And then we said neural causes. So epilepsy is the one that we always like to talk about. Stroke as well, an older person. But let's not forget things like an encephalitis or a meningitis. We talked about subarachnoid hemorrhages and epidural hemorrhages. Or it could be that somebody has Parkinson's and has fallen over because of that, something neurodegenerative. Finally, post-neural. The way I look at it, this is the most controversial one. Anush is smiling to himself. This one's really controversial. Don't bring this up with geriatricians or anything. But the idea that sometimes people fall because they tripped over. Now, in the world of geriatrics, people don't just fall because they tripped. There is always a reason. Was it because their vision has gotten poorer so they couldn't see where they were going and they tripped on something? Was it because their balance isn't too great? Is there a vestibular cause? So I've put tripped, fell, and hit head, which sometimes is referred to as a mechanical fall. But if you Google mechanical fall, you will see so many opinion pieces and blogs and articles from literally geriatricians, so many geriatricians going, there is no such thing as a mechanical fall. This is a useless term. It's, it doesn't have one consistent definition. Don't use the phrase mechanical fall with me. So if you're ever with a geriatrician, for example, Lexia, don't say mechanical fall. So post-neural, I've just put there for the sake of having a post because I've put a pre. And sure, maybe someone like someone our age might just trip and fall down the stairs for no other reason than we tripped, but in an older person, don't mention it. It's a really touchy subject. I haven't tried it. I don't think I'll ever plan on trying it. But literally, if you divide it into this, was it something that happened before the brain that affects the brain, like a drop in blood pressure, or distributive shock, which will also cause a drop in blood pressure? Was it something to do with the brain itself, like epilepsy or a stroke? Or did they just fall? Probably not, especially if an old person falls, there's usually a reason other than they might say, I just tripped, or I just slipped, but usually there's something more to it. They were incontinent and they were rushing to go to the toilet, and that's why they slipped. Maybe in our age, somebody got really drunk and slipped, but you could also argue that's neural technically, or pre-neural because of the effect on the vestibular system. But that brings us to an end. Takeaways from my point: divide your history into pre-loss of consciousness, during loss of consciousness, and post-loss of consciousness. And if you're thinking about reasoning, then pre-neural, neural, and inverted commas post-neural. Anush, I think he's looking for the feedback link.
I am always looking for my feedback form. There's a link for that. So yeah, basically, takeaway things, as Ahmed said, an approach to loss of consciousness, which is easily the hardest history that you can be asked. If you can do this history, you can do any history in medicine.
Basically.
Genuinely. And how do you approach someone with a very common problem like swollen legs? But yeah, hopefully, I think this session illustrates quite well that anything can cause anything in medicine. And so always try and think outside of the box. If you have any questions, let us know. If you could fill out feedback, we'd really appreciate it, as always. If you like the design of this kind of session, because this is what we did mainly last year, and the plan is to go back to more sessions like this with the others this year as well, let us know. And the other thing I was going to ask was if you guys would like a session on diabetic medication. That's something we could do. Me and Ahmed love pharm, basically. And I am aware that that's something that people struggle, like antibiotics, it's important super well, and people struggle with. So let us know. Let me stop the recording.